So welcome everyone to today's session, MedDRA Coding Basics. Welcome from me again, and thank you, Leander, for the introduction. So here I am on screen, and if you're listening back, there I am. My name's Jane Knight, and I'm a clinical associate with the MedDRA MSSO. And now we'll move on to the material. I'll switch my camera off at this point because I know it can be distracting for you all. So the first slide explains that MedDRA came about in the mid-1990s. It was an M1 initiative from ICH, and at the time the MSSO, whom we both work for, the Maintenance and Support Services Organisation, were put in place to maintain and distribute MedDRA. The activities of the MSSO are overseen by a management committee with representatives from across the ICH regions, both the industry and the regulatory authorities. Now, just a reminder that MedDRA is owned by ICH, as is the material that you'll see today. So if you choose to use the material or change it in any way, you must acknowledge ICH as owners, and you must explain any changes that you've made. If there are any slides which say that they're courtesy of a third party, the approval to use them does not go with those. You have to get copyright approval separately. This is what we're going to cover today in the next 2 hours. You've got plenty of time to talk about MedDRA and ask all your questions. We're going to start with a brief recap of MedDRA's scope, structure and characteristics. I'm not going to spend a lot of time on that because we have another webinar called What is MedDRA and How's it Used, which some of you may have already attended. If not, you can listen back to that as a recording. We're going to discuss coding conventions, look at the MedDRA term selection points to consider document, and learn about MedDRA browsers. We'll use the browser, the web-based browser, for coding and showing you how we would code with some examples, applying the principles from the term selection points to consider document. And throughout the session, we will have questions. We won't just answer these at the end. We'll do them throughout the session. So there's plenty of opportunity for you to ask questions and get a response. We'll also be doing some quiz type questions to keep you on your toes during the session, and you can join the quiz either on your mobile phone or on a computer browser by typing in polev.com at the top in the URL field. That will link you to the presentation. You see the screen on the right hand side. When it asks for a username, you enter my name, Jane Knight 855, and then you click join. Alternatively, you can scan the QR code. That's the easier way to do it, and it will take you direct into the presentation. So I see we're still having some attendees joining us. So while everybody's joining, it's a good opportunity. If you want to join the quizzes, then you can vote on how terms should be coded. You can join by scanning the QR code or following the instructions. And if you forget, Leander's put the details in the chat for us already, and you can ask her and we'll show you again. So the first one, I see somebody's there already. Where are you from today? Shelter Farmer, that's your company. Bucharest, somebody else from Romania, 2 of you. We did some training in Romania last year and had a really lovely time there. And Bulgaria, we met people from Bulgaria while we were there in Romania. Nice to see you all. Finland. LMST, I think, is your company. India, welcome wherever you are. Oslo, someone from the UK like me. Portugal, nice to have you with us wherever you're from. London, cold London today, I expect. Claire, welcome Claire. Portugal again, wherever you are, welcome, welcome. Botswana. I always feel this is a privilege at this point to be able to do this and link up with you all. It really is a humbling moment, I find, in these webinars. So welcome, Prague, Spain, all over the world, welcome. So as I mentioned, we're going to do a recap of what you probably already know. So MedDRA is a clinically validated international medical terminology that's used by the regulatory authorities and the regulated biopharmaceutical industry. It's used through the entire regulatory process from pre-marketing to post-marketing, and for data entry, retrieval, evaluation and presentation. So nothing new there, but what I want to emphasize is standardization. It's standardized because it's used in the same way by both the authorities and the industry and throughout the whole process. MedDRA is used for data entry, encoding, which is going to be our focus today, also for retrieval, evaluation and presentation. And there are specific features of MedDRA built in to assist with retrieval, evaluation and presentation to ensure the quality at that stage as well. And we do webinars on the retrieval, evaluation and presentation stages. It's clinically validated because it's designed by physicians. It's international because it's available in a number of languages, English and Japanese, as well as many other translations. So that covers the key things. And as I said, it's used through the entire regulatory process. So it's not, in the past, you may have had a different dictionary used for drug safety, post-marketing. Now MedDRA is used for everything. So that gives you an overview. As we said, it's used from clinical phase 1 right through to phase 4, including marketed products and ICSRs. We typically think of MedDRA being used in databases or in clinical study reports, ICSRs, but there are some other uses that we may not automatically think of, the investigator brochures or applications for a license to market, publications. Academia use it quite often now as a tool for analysis, and then prescribing and advertising in some parts of the world. So you see it's broader than we might automatically think. I won't spend long on this one because the point I want to make here is if you look within the blue circle to see what's included in the scope of MedDRA, it goes way beyond just signs and symptoms. It can be used for indications. It's got terms in there in a specific section that are used for coding investigation results. So if something's reported as an investigation result, you can find a MedDRA term for that result or even that test name. There are MedDRA terms to capture procedures, maybe when reported as medical history. There's also terms for medication errors, as we'll see later, product quality issues, product use issues, many other things as well. So it's very, very broad scope. There's a large number of terms as well covering this broad scope. There are 27 sections or system organ classes. That's the most general level of the hierarchy. And then you see it is hierarchical. The terms are grouped systematically in clinically relevant groupings. Within each system organ class, there'll be a number of high-level group terms or HLGTs. Within each one of those, there'll be a number of high-level terms, and we'll see this branching. Look at the numbers. You see how the numbers increase. It branches as we come down the hierarchy. By the time we reach the preferred term, that's the medical concept. If you like, that's your diagnosis for a report. And beneath that, we have lowest level terms, which tend to be synonyms or close synonyms. Sometimes there's a little bit more information provided at the LLT level, but generally they are synonyms of the preferred term. And it's the preferred term level that's used mainly for medical review or for analysis. So you'll see that. But today, our focus when coding is to choose the closest, lowest level term to what's been reported. That's the overall aim of what we're going to do today, what we're learning together, how to choose the closest LLT to what's been reported. The preferred term and the hierarchy automatically default. They're hard-coded. We don't need to choose those. We're just looking to choose the closest LLT to what's been reported. This is the list of 27 system organ classes. You see that there's a number of body sites, but not exclusively body sites. There's also some sections which contain procedures, investigations. So the terms are grouped there by etiology, by purpose, and some conditions as well by etiology. Neoplasms, infections are grouped together regardless of body sites. And then we've got some other support socks like pregnancy and general disorders, which includes death terms and some others. So you can see that for yourself in the browser. This slide shows you an example of showing the hierarchy for the preferred term of arrhythmia and some of the LLTs that sit below that preferred term. So remember I said the preferred term is the medical concept. We see that it's within the cardiac disorders. We have an HLT, so a grouping there of rate and rhythm disorders, not elsewhere classified, NEC. So a miscellaneous grouping of rate and rhythm disorders which don't fit in anywhere else. These are grouped within cardiac arrhythmias. So there will be specific types of arrhythmias there which have their own HLT. And what we're seeing here is the miscellaneous group, which includes the preferred term of arrhythmia. And at the bottom, you see the LLTs, just some of them there. Arrhythmia not otherwise specified, so an unspecified arrhythmia. We only use that if it's actually reported to be unspecified. We don't assume a thing is unspecified, anything just because it doesn't say so. Arrhythmia, so the copy of the preferred term. And then we've got a non-current term, other specified cardiac dysrhythmias, and an LLT for dysrhythmias, so a synonym there. As I said, most of the LLTs are close synonyms or synonyms. Non-current terms, we saw there was one on that slide. These are terms that we no longer use in coding. They are flagged, and you can see on the top right-hand side, the little icon there for LLT. That's what you'll see in the browser. That's how you know they're non-current when you look in the browser. They're there to preserve historical data for retrieval and analysis, but very often they're vague or ambiguous, outdated, truncated, or misspelled. And they may even be terms derived from other terminologies that were used in the past, like whoart or co-start or ICD-9 that was in use back in the 90s when MedDRA was first released. So terms which were in use at the time, they may have been brought into MedDRA, but they don't fit the MedDRA rules. So although they're there to help with transfer of data from a legacy terminology, they're no longer used for coding. So here's a quiz for you now. Which of these do you think are non-current? Remember I said it's terms that don't fit the MedDRA rules. Which ones are non-current? And I'll give you a clue. There's more than one here that's non-current. Perhaps I should be asking you why you think they're non-current. So ask yourself, when you're choosing, have a think about, well, why would that one be non-current? Well, the most popular seems to be abdo-bloating and MI, although there are votes for all four options. So are we done? Shall I tell you the answers? Everyone had a chance? Well, it's probably a bit of a trick question, really, because they're all non-current. The first one's non-current, MI, because it's an abbreviation, and it could be myocardial infarction, but it could equally be mitral incompetence, mental illness, myocardial ischemia. It could be other things depending on the therapeutic area. Insomnia with sleep apnea is a combined term. You've got two conditions there reported together, and MedDRA terms are very much a splitting dictionary. They only capture one unique medical concept per preferred term or LLT. Bloody drainage. Well, the problem with this one is that drainage is ambiguous. It could be a procedure for draining with a device, for example, or it could indicate that there's been a bloody discharge. And the reason why that one's made current is because MedDRA drew up conventions about how to interpret the wording of these terms. So you can see the detail of that in the introductory guide. And abdo-bloating, well, that one's your most popular choice because, as you can see clearly there, it's an abbreviation. It's truncated, isn't it? Abdo. So MedDRA would prefer to have the term abdominal bloating there. Well done, all of you. Well done on that one. So now we see an example of a preferred term, anemia, and there's the numeric code that underlies it. We tend to think of MedDRA terms, but each MedDRA term is also assigned an 8-digit numeric code. This doesn't mean anything. We can't break it down and say, well, because it starts with a 1 or it ends with a 4, it's a blood disorder. We can't make any sense of it like that. It's just that the next term that's added to MedDRA is given the next number. The numbers are assigned sequentially. But the codes can be useful. Some companies use them in the electronic submissions like the E2B file or for saving space in your database. This slide, a very busy slide really, but it shows you just how many translations of MedDRA we currently have or we have planned. Here we see, I think it's 32, and there's even some other languages on our radar which we're looking long-term to develop. So we can see there, I know some of you are Portuguese, Romanian, who are Spanish. We had some of you in the group with us. Bulgarian. You can see there that some of the languages are currently available, some of them are coming. So just bear with us, they're coming. Usually we get a couple a year, couple of languages a year we're getting. Arabic, some of you on the call may be Arabic speakers. That one we do have came out about a year ago, a year I think exactly it went. So this shows you the numeric code in the center. It shows you that that is the key and you can use that code for translation. So this, what we're looking at here is headache, and that's the numeric code for headache. It's the same numeric code in all the languages. So if you do work in some area where you need to do translation, you can use that numeric code to do your translation. Hopefully that makes sense to everyone. So now I'm going to pause for questions because this next section is very important that you understand. So I'll pause for questions to get everyone back grouped again and clear everyone's minds. Any questions, Leander?
Thank you, Jane. There's currently no questions. We've had some comments and it's welcome to everyone. I'm so pleased you can all join us. So it's lovely to see people active on the questions, but there's no current questions to read out. Thank you.
Wonderful, thank you. So now we're going to talk about multi-axiality. Now, multi-axiality refers to the situation where we have one medical concept represented in multiple system organ classes. This allows you to group that medical report in different classifications and retrieve that report in different data sets. So let me give you an example. I could ask you, if you received a report of allergic arthritis, which system organ class would you expect to see that in? Now, I don't have a poll, but we could do a virtual poll. Hold your hand up. And I'm sure around the world, if I said which sock, some of you would be saying allergic arthritis, that must be an immune condition because an allergy is an immune problem. Others of you may be working within the musculoskeletal therapeutic area in joint problems, and you might focus on the arthritis and say it's in the musculoskeletal system organ class. And both of you would be right because the preferred term of allergic arthritis is in both of those socks. The primary or the default is the musculoskeletal and connective tissue sock, but there's also what we call a secondary sock of the immune system disorders. And this allows us to group all of our allergic conditions together by activating the secondary sock when we do our analysis. Now, it's important here to stress that you mustn't change the primary sock. Every preferred term has a primary sock, and this is what you see when you have cumulative data outputs. You have your listings, your PSUR or your PBRA, your clinical trial report, and that's what you see there. But it prevents double counting by having a primary sock, and it supports standardized data presentation. So you mustn't change it. You never choose the sock when you code, and you mustn't change the primary sock. Here's an example of influenza at the bottom. We see it's in 2 socks, and this one's a bit unusual. Remember when I gave you the list of 27 socks, I told you that some conditions are grouped by etiology. Well, infections are all grouped together in the sock of infections and infestations, regardless of body site, and that's why we see that influenza is primary there, secondary is respiratory, so the site of manifestation here is secondary. And in a listing you'd see all the influenza cases together with other infections, but if you wanted you could do an analysis that groups it according to all the respiratory disorders together. So how do we know what that primary would be? Well, if the preferred term only has one SOC assigned, that will automatically be primary. But if there are more than one SOC assigned, they all call secondary. They're all secondary, they're all equal, there's no ranking among them, but they're grouped according to this site of manifestation, as you see here, this ruling. Site of manifestation is where the primary would be. So allergic arthritis is primary to musculoskeletal, but there are 3 exceptions, and this won't surprise you because we've just seen the infections. So the 3 exceptions to the rule are congenital and hereditary anomalies, which have a SOC of congenital, familial and genetic disorders, neoplasms, and the only little exception there is that cysts and polyps, although they are neoplasms, they're actually placed in their own body site. And thirdly, as we saw with influenza, infections and infestations. So those are our 3 exceptions. If there is a preferred term which has a link into 2 of those, this is the order. So they would be primary to, if there was a congenital teratoma, for example, a baby born with a neoplasm, it would be primary to congenital and secondary to neoplasms. And then the same with if there was an infected neoplasm or a congenital infection, it would be primary to either congenital or neoplasms and then secondary to infections. And just a reminder for you, less important today, but this is important when we do retrieval webinars, that remember some of the system organ classes don't have any multi-axial links. So investigations, surgical and medical procedures, and social circumstances. So that's a piece of information to file away for when you come on to learning about retrieval in your Learning with MedDRA. So here are some quiz questions for you again. I've got 3 of these. In which system organ class would you expect to find the PT of deafness? Deafness. Where would you expect that to be? I know it's very small on a phone, very small to get your finger on the button, on the spaces. You're doing a great job though. So we've got a few strays there, just I think with the difficulty getting it on the spot, but you're all agreed there that ear disorders, and some of you who just missed the square, ear disorders would be the primary, exactly right. And then nervous system, some of you go for. So some of the hearing disorders do also have a link into nervous system disorders. So it's always worth having a look. Some of the special senses terms do have a secondary for nervous system. So, and deafness, yes, nervous system would be a primary. So ear disorders, well done. The next one, where would you expect to see panic attack? Panic attack. Oh, you're quick, aren't you? Psychiatric disorders, psychiatric disorders. Oh, look how many of you there are. Yes, exactly right. Psychiatric disorders for that one. Well done. And the last one, where would you expect to see breast cancer? So remember the rules that we just talked about. Breast cancer. Great to see so many of you online today and so many of you voting. Well done. So neoplasms is the most popular choice, and that's exactly right. Remember the rules, that would be the primary, and the secondary would be reproductive system and breast, which is what you've gone for. Few of you have gone for congenital, so we wouldn't code congenital because there's nothing there suggestive in the term that it's a congenital disorder. It's a neoplasm, so that's why we would select that one. Well done. Oh, another one for you. Once you've selected the LLT that represents it, what do? Do you choose the primary SOC or do you follow the predetermined MedDRA hire? Oh, thank you. Well done. I'm so pleased. That shows reinforcing what we've said. It's a very important point that you must always follow the predetermined MedDRA hierarchy. Very much so. Thank you all very much. So now we come on to coding and what we're here for today. So let's think a bit to start with about coding conventions. Well, what are coding conventions? They're written guides and sets of principles for using MedDRA that help us achieve consistency in our coding and also data retrieval. Conventions harmonize exchange of MedDRA coded data worldwide. Remember I said at the beginning, MedDRA is all about standardization. Well, if we're using MedDRA, but we're using MedDRA differently between our companies or our organizations, then we're not going to get that harmonization or standardization because we're assigning the MedDRA terms differently to the reported events. So we need to be assigning the terms in the same way for consistency. And we also need to make sure we've got quality of what is being reported to us. So here we see that some companies have conventions that they will always query certain terms and ask for follow-up with the reporters for misspellings or abbreviations or acronyms. Combination terms, do you code them? And if so, do you have a convention on what you code it to? Or do you query them? And then other terms that things like chest pain, some companies call block terms, which would always get queried to ask, is that chest pain cardiac or not? So these are what we mean by conventions. Why do we need them? Well, we all come into MedDRA and coding from different backgrounds. We have different medical knowledge, different aptitudes. And also because MedDRA is so large, we saw before just how many 87,000 terms there at the LLT level compared to the older terminologies, which may have had 2,500 preferred terms. MedDRA's there with 26,000. So even with an autoencoder, companies that use algorithms or artificial intelligence, even nowadays, machine learning, there will always be a need for manual coding. So you need to have conventions to guide the choices, whether that's a machine or a human, and to review. Machines can also make errors. We've got a couple of examples here. Allergic to CAT scan was auto-encoded by a machine that focused on the word cat as allergic to cats. Or myocardial infarction in the fall of 2000 was coded to myocardial infarction and fall, when fall really in this scenario means the season. It means what I would call autumn. So you can see there how important it is to review not just human coded, but also machine coded coding, machine coded terms. So there is an ICH approved industry coding guidelines document called the Points to Consider, MedDRA Term Selection Points to Consider. This provides term selection advice for industry and regulatory purposes. The objective is to promote accurate and consistent term selection that facilitates a common understanding of shared data. And it's recommended to be used as the basis for an individual organization's own coding conventions. So what this means is you mustn't make any coding conventions and document them which contradict anything that you'll see in this MedDRA term selection points to consider. You see the date there is March 2023. That's because it comes out annually on the 1st of March. It's developed by a working group of the ICH Management Committee. I won't go through all the languages, but I'll just say that sometimes there will be the whole document is translated into your language. Sometimes you'll have a summary version, and in some cases we don't have the translated documents for all of the languages. That's because our focus is on getting the languages out for people to use, and in some cases the paperwork follows on, or in some cases we may not have the full PTC document for every language. So check before you look for it. In some cases, there's more than one option in terms of term selection, and the document gives you a preferred option. But it doesn't mean you have to use the preferred option. If it suits your coding conventions, you can have the alternate option. But the main thing is that you document the choice you make, and you should always be consistent in your choice. In the document, if you're interested in versioning, there's some information in the appendix about versioning. Not relevant to what we're going to do today, but it's there if you need it in the future. So now we're going to look at the term selection principles in the first part of this document. I'll pause again. Leander, do we have any questions?
Thank you, Jane. Currently, no questions.
Good. Well, hopefully it's okay for everyone. I went quite fast there because I want us to get onto the actual coding elements of the webinar today. So that's why we went quite fast. But if anything's not clear, please do send Leander a little text in the tool and we'll stop and answer your question. So let's go through these principles one by one. The first two principles relate to quality. Firstly, the quality of the source data that you receive, and secondly, quality assurance in all of your data handling processes. So the quality of the original information you receive impacts the quality of the output. They say, don't they, garbage in, garbage out. So if you receive anything that you're not clear about, or maybe you feel you need to ask a colleague, what do you think this means? That's a good indication that it may is ambiguous or vague, and you should obtain clarification of the data. Sometimes you can optimize the clarity of the data by design of your data collection forms. Also training, if you work in drug safety, train your colleagues in the affiliates around the world who may pick up the phone and collect and document, take the reports that are coming in from consumers. In terms of quality assurance, making sure your coding guidelines are consistent with the term selection document that we've just talked about. Make sure that you review the coding by the individuals as well as the automatic coding. Look at what we've just seen with the allergy to cats coming from a CAT scan. So it's very easy to see how machines can go wrong. So here I have an example for you to illustrate the concept of quality. You receive a report of abuse. What would you do? Would you query it, seek clarification, or would you code it? Well, I think we're unanimous there. Some people are changing your mind, seeing where everyone else has voted. But it seems like immediately you would think, like me, we need to seek clarification. Yes, we do. Because abuse could be that the patient is a perpetrator of physical or psychological abuse, spousal abuse. It could be that it's drug abuse. Could be that somebody's a victim of abuse. So we just don't know what's happening there, and very different interpretations. So we need to seek clarification. Here's another one. Compression, T4, T5. What about this one? Again, somebody in there is jumping straight in to seek clarification, some of you. That's quite right. So now I'll ask you the question, why? Why can't we code the reported term of compression T4, T5? What's wrong with it, quality-wise? Why do you want to seek clarification?
Jane, would you just mind making the QR code slightly bigger just for a moment so people can have the opportunity? Thank you.
Because it's ambiguous, it's two terms. Shortage, two separate terms. Do you mean it's abbreviated there, T4 to T5, the shortage comment? Maybe because it's don't know what's meant by T. That's exactly right. No reason or substance. It's unclear. It is unclear because we don't know what's being compressed. Somebody's telling us it covers two areas. That's right. So is it the nerve that's being compressed? T4, T5, is it the spine? So is it the spine? T4, T5 to me suggests it's thoracic vertebrae. But is it the intervertebral disc that are compressed? Is it the nerves around the spine? Which anatomical structure is compressed? Somebody's expressed that perfectly. Look, well done. Thank you very much for that. Which anatomical structure is compressed? I couldn't put it better myself. And T4, T5, are we happy with those, with that abbreviation? So that's why. Thank you. The next principle is do not alter MedDRA. I emphasized this before and you did a poll to reinforce it. MedDRA is a standardized terminology with a predefined term hierarchy. Users must not make any ad hoc structural alterations, which would include changing the primary stock allocation. If you think a term is incorrectly placed, submit a change request to the MSSO. Some of you might be working for CROs and you have sponsors who are not as familiar with MedDRA and they ask you, can you change the SOC of this one when you send them listings? We must never do that. Regardless of the situation, we must always code it to the predefined term hierarchy. And if you need pushback, it's available in the MedDRA Best Practices Guide online. It's available in the Points to Consider, both the Points to Consider documents. And also you can tell if you get asked by a colleague or by a partner organization, the regulatory authorities will just revert it back to the standard MedDRA terminology hierarchy. So you're not really gaining anything. Even if you think you do send a data set in and it's coded in a strange way to a different SOC, the regulatory authorities will revert it and they're more likely to question what else you may have done that's different and why did you need to change it. I've emphasized that enough, I think. So as I said before, our aim today is to learn how to select the closest LLT, but we only select current LLTs, the LLT that most accurately reflects the reported verbatim information. Abscess on face. Well, we could code it to abscess, but look what the little pictures show us. An abscess could be on the skin, in the tooth, in the brain, in the lung, plus multiple other body sites. We know it's on the face, so we would look for a more specific term. In this case, we would find facial abscess, and we would search that by looking for the word stem, F-A-C, face or facial. Here's another term for you. How would you code red skin on soles of feet? Red skin on soles of feet. I'll give you a moment. Some of you are in there straight away with the right answers. Look at that, how popular. So plantar erythema is our first choice. That's your most popular choice. Some of you are going for skin red because the verbatim says red skin. Some of you are going for erythema and some of you are going for redness or localized erythema. Well, skin red is a synonym of erythema. So we're not gaining anything. If we just code skin red, that's a very general, vague term. We're losing the site. So we want to capture the site. So do we go extremities? Do we go legs? Well, soles of the feet is not exactly legs. So that's not my first choice. Localized? Well, it is localized, but can we be more specific? Erythema is a synonym for red skin. Plantar means soles of the feet. So as you all selected, plantar erythema. Well done, well done. The next two principles are when you should request a new term to be added to MedDRA and when you should use medical judgment and find something which adequately represents the concept, even if the wording is slightly different. So the principle is you should avoid company-specific workarounds. If you see a gap in MedDRA and the concept is not adequately represented, please send us a change request because it might be that it's a new condition, a new treatment, procedure treatment that you can ask to be added to MedDRA. And you're helping yourself as well as all our other users, and you're helping us keep MedDRA up to date clinically. If there's no exact match, use medical judgment to find a term which might be there but with a synonym. And so use a medical dictionary perhaps. So now I've got an example for you. Splitting. How do you code left foot and ankle swelling? Left foot and ankle swelling. Would you code swelling of feet and ankle swelling? Would you code peripheral swelling, unilateral leg swelling, or local swelling? Only 2 choices this time. Oh, somebody's thinking about peripheral swelling. Well, let me show you the placement of the term in MedDRA and you'll see the answer for yourself. So here we have the 2 terms. The suggested correct answer is swelling of feet and ankle swelling. And this slide shows you why. Swelling of feet falls under peripheral swelling because feet is an area of the body, whereas ankle is actually a joint. MedDRA treats ankle as a joint, so it's placed under the PT of joint swelling. So ankle swelling is under joint swelling. Swelling of feet as a region is under peripheral swelling. When you see that there are 2 separate preferred terms representing these 2 concepts, then that's a good indication you need to split code. Okay? When you see the 2 PTs, you need to split code. So I've got another example for you. Pain in hand, severe pain in leg and toe. Pain in hand, pain in leg and pain in toe is your first choice now, or is it pain in extremity or one of the others? Remember the concept we just said, how you check. Do you need to split it or not? Well, I haven't given you time to go to the browser and look. And I don't expect you to know every single term in MedDRA. Any more thoughts before I move on? Can you generalize it to pain in extremity, or do we need to split code? Well, again, let's look at the placement. And in this scenario, it's okay to code pain in extremity because when we look at the hierarchy, we see that, see if I don't have it highlighted, sorry. Pain in hand, pain in leg, pain in toe, pain in calf, all of those things we had. What did we have? Leg, toe and hand. They're all LLTs under the same PT of pain in extremity. And it tells us in the MedDRA term selection points to consider document that when you have set LLTs and they're all under the same PT, we don't need to split code. So this is the opposite, the flip side of the example I just gave you. Here we don't need to code, we split code, we can code it to pain in extremity. Well done. Some of you got that one, so if you did, give yourself a pat on the back. Now check the hierarchy. Cervical spasm complicating IUD insertion. Spasm uterine cervix. Now what's important here is we've looked at the hierarchy before choosing the term. You might not see it here. Cervical spasm, well, IUD is clearly an intrauterine device, so why wouldn't we choose spasm uterine cervix? Uterine spasm, nothing unusual there. But look what we could have done. We could have chosen the LLT of cervical spasm, and that would have been disastrous because that one would code up the hierarchy to muscle disorders, and that's clearly not what we've got here. So this is reinforcing for you, before you select an LLT to code, make sure that you check the hierarchy to make sure it fits. Ventricle rupture due to pre-existing hydrocephalus. Cerebral ventricular rupture. Well, again, of course, hydrocephalus is fluid or water on the brain. It's a brain condition. Why wouldn't we select cerebral? Cerebral ventricular rupture. Because there is also a MedDRA term of ventricle rupture. So you need to make sure you don't just grab, based on the wording, don't just grab the first term you come to, because ventricle rupture here is a myocardial disorder. It's a cardiac problem. So we need to look for cerebral ventricular rupture. So always check the hierarchy when you think you found the best term for what's been reported. The next principle is to select terms for all the reported information. Causality is handled elsewhere, not in coding. We code everything, whether it's a device-related event, product quality issue, medication error, medical social history, investigation, indication, whatever it may be. but we don't add any information, and we certainly don't infer or diagnose. If you have only the signs and symptoms reported, in this example we see abdominal pain, increased serum amylase and increased serum lipase, a doctor might see the patient probably has pancreatitis. But we can't make that decision. We can't make that diagnosis. We need to code what has been reported, and that means splitting out the signs and symptoms, the lab results, and coding them individually. Here we code abdominal pain, serum amylase increased, so that's a lab result. That would be in the investigation SOC, and lipase increased, another abnormal lab result. And then moving on to section 3 of the MedDRA term selection points to consider document, the document then goes through a number of different types of data and how you code specific types. So here is a list of the sections in the points to consider document. I've got another slide which follows it. And I would urge you, if you're not familiar with this document, if you are new to MedDRA, please do have a look at it. Take the time after the session to look at the document, read the details of how you code each of these different types of terms, and it can become your go-to reference document when you are coding. And you will find that it covers the vast majority of the type of terms you receive. So we'll go through some of these today. We'll go through a few more of them when we do our advanced coding webinar next week. So if you want to join us again, you'll be very welcome, and we'll go through more of these then. So before we go to the browser, I'll pause again. Leander, do we have any questions?
No, not at this time, Jane, but thank you for asking.
Good. Well, hopefully everybody's with it. I haven't lost you along the way, I hope. So let's look now at the MedDRA browsers. The MSSO provides you 3 browsers as part of your subscription. The first is a desktop browser. You download it from the website and install it on your desktop. The second is the web-based browser, or WBB. This one is, as it suggests, it's web-based. It's on our server and you access it using a URL. Both of them need your password. The web-based browser, you need the password to access every time, whereas the desktop browser, you need the password to download it initially. But once it's downloaded, the desktop browser is available on your desktop. You don't need access to the internet to use it. But the benefit of the web-based browser is that it's updated centrally every 6 months with each new release of MedDRA. The web-based browser includes all the versions of MedDRA and all the languages, whereas the desktop browser, if you want to see a second language or if you want to see different versions, every 6 months you need to import the new files that get released on our website. So the desktop browser, yes, you can use it offline. So if you have a bad internet connection, or you want to use it when traveling, it's helpful. But the web-based browser has everything all loaded already in it centrally by us. And on the right-hand side, one that often gets overlooked is our mobile browser. The mobile browser is URL. It's not an app that you download from the App Store. You access it via a URL, but it has a much larger interface, and we can see that on the screen here. It's better for use on a mobile or a tablet, a phone or a tablet. Each of the browsers, I've told you most of this, they all need your MedDRA ID and password. They all allow you to view MedDRA and the SMQs. SMQs are standardized MedDRA queries. It's something that we use for analysis that we don't touch on today. But if you're interested, you can come along to another webinar. They both support all the MedDRA languages, but there's more manual importing needed in the desktop if you wish to see the languages. They offer this language-specific interface, and you can also export your search results and build queries using a feature called the research bin in the desktop browser and the web-based browser only. In the web-based browser, you can see, if you have a look at the picture here, the screen's turned pink. That's because it's what we call the supplemental view, and this is where you can see the changes that have been approved for release in the next version of MedDRA, but they're not yet part of MedDRA. So although a user may have asked us to add a new term to MedDRA, we've agreed to add it, but at this point in time, it's not part of the current version. It's waiting for release. We're waiting for the 1st of March for our next release, so there will be terms in that, and those are known as supplemental changes. The browsers allow you to view secondary and primary SOC allocations. They allow you to do some analysis using the SMQs that I mentioned earlier. And when you search, you have what we call the advanced search option, which is when you change the Boolean operators and you can look for and or, not, begins with, ends with, that kind of thing. A bit like you would if you had an advanced Google search when you do a more detailed search. So I'll do a demonstration now of the browser. So I'm going to go to the website, and the quickest way to access the browser is the top right-hand side, the quick links, WBB, web-based browser, but you can also access it from how to use, tools, and then there's a browser section there as well. There's a browser page, and on the right-hand side, there's the link for the web-based browser. You get there the same way. Oh, it's turned me to a Chinese version of MedDRA today. So there we go, English release. And there we go, log in, MedDRA browser. So there are 3 main sections. On the left-hand side, we've got the hierarchy. This is where I tend to think we browse, and we do top-down browsing. So if I click on the SOC name, it will open down the hierarchy. And we see here the HLGTs are very general. The HLT is general. I've opened gastrointestinal ulcers and perforation, site unspecified, or gastric ulcers and perforation. Let's go gastric ulcers. And we see there the preferred terms for gastric ulcer. Now we've got gastric ulcer, gastric perforation. We don't have one condition there. Each PT is a condition in its own right. Gastric ulcer, for example. Underneath gastric ulcer, we see the LLTs. Some of them have a little bit more information, antral ulcer, or what else have we got? Greater curvature somewhere, the site of the ulcer, lesser curvature gastric ulcer, pyloric ulcer, giving us the site of the ulcer as well as the fact that it's gastric. The ones with the red box at the LLT are non-current, including GU as an abbreviation. So that's what I was telling you before in our overview. The middle of the browser allows you to type in what you're looking for. Remember, we were looking for, we were looking for facial abscess, weren't we? And I said, do the word stem of FAC. If I was looking for diabetic retinopathy, I might do the same again, diabet and retin, because then I'd capture diabetic, retina, retinal, retinopathy. And you can do that. You don't need wildcards. This gives us a bottom-up search because we get the results at the LLT level. There are tabs for LLT, PT, or any other levels. But when I find the term I'm interested in, diabetic retinopathy, for example, I can click and go up the hierarchy. We can see that this one's multi-axial. It has links into 3 HLTs, 3 HLGTs, and then that splits even into 4 SOCs. So we see that there is multi-axiality here. There's the primary, the eye disorders for that one. We can tell by the icon. And a nice feature, when you find the term that you're interested in, you can do a right-hand click and go to browser. Remember I told you that it's important you check the hierarchy of a term. And this is how you do that. You do a right-hand click and you can look at the hierarchy here within the MedDRA structure, or a nice little summary at the top telling you the hierarchy for that term. I clicked on the preferred term of diabetic retinopathy, but by coming over to the browser, I can look through all the brothers and sisters and check that I have actually got the closest term that matches my reported information. So good practice is to find the term you're interested in, but make sure you check the hierarchy and also check brothers and sisters to make sure that you do have the closest term. When you put your cursor on any term, the right-hand panel tells you information about the term. It tells you the MedDRA code, the placement of it. Here we see that the eye disorders is the primary SOC here. Let me get my highlighter. Here we see that the primary SOC is eye disorders for diabetic retinopathy, but it has 3 other secondary SOCs. All of them are secondary, so they're not primary. And if we wanted to look at all the diabetic complications, we could do an analysis by activating these, but that wouldn't be your primary analysis, that wouldn't be your main listing, and it wouldn't be the SOC you choose when you code. And at the bottom of this screen here, we see we have information about how the term is placed, the multi-axiality of it. So let me get rid of the highlighting. There we are. So that's the 3 main sections: top down on the left-hand side, bottom up by typing in and searching, and then more information on the right-hand side. Across the top, we have some buttons. So we have MedDRA concept descriptions. So the MedDRA terms themselves don't have definitions, but it's useful for some of the terms to have a description of the concept. So abuse or addiction, aggravated, or what's an application site. So things like this, you can look them up. If we click on one of the letters, let's go for D, we can see what device use error, we can see the difference between dose and dosage. These concept descriptions are very helpful, in particular for coding of medication errors and product quality terms. So that's one of the tips I would say take away today. Remember, they're here. They can help you with your coding. Along the top, this is where I mentioned that the web-based browser offers you all the languages. So I could pick another language. Let's see we can see the languages we've got here. Now, Portuguese, we had some of you on the call today where said we don't want to translate it. So you see immediately we've got the SOC name is given now in both English and Portuguese. I can choose 3 languages. Here I've chosen 2, English and Portuguese, and it would be the same if I do a search. Let's do, for example, heart failure. We can see here we've got heart failure, insufficiency cardiaca. Here we are. Do you see? Exact match and lexical match, the word order. Synonyms, this means that the browser knows, because I searched for heart failure, it's giving me terms that use the word cardiac. And that's because it knows that by searching for heart, I'm interested in cardiac. And then down here we have another category of contains. And these are all the terms that contain the words I've asked for. So heart and failure. So we're seeing acute heart failure, chronic heart failure, other terms which include the words I've looked for. Synonyms include the word cardiac instead of heart. So you see here. And if you're wondering where those synonyms come from, you can click on the hyperlink in the center of the screen and see the synonyms that are built into the browser. Okay, I just give you a pause to let that sink in. So that's the languages, the same drop-down feature here to select the version of MedDRA that you wish to see. I should be using version 26 for this coding today because that's the version that our training materials are based on. And you can switch, if you want, you can filter. When you do a search, you can click on one of these SOCs here on the right-hand side and limit your search to just within that single SOC, or use the control or the shift key to choose several socks. That can be quite helpful to reduce the number of terms that you retrieve in your search. If you know, for example, that you have a surgical procedure reported and you're not sure what it is, well, you can limit to the sock of surgical and medical procedures here, and you could type something in and you'd only be looking within this sock when you receive the results. The one thing I would say though is if you do that, make sure you clear the selection before you move on and code some other terms. Going back along the top, I've told you about concept descriptions. You can also, a useful link is also to the MedDRA documentation. When we click on this, takes you immediately to our website, and this is where you find the points to consider document. So points to consider, term selection, and also I mentioned best practices. This is where you've got more information about the importance of using the primary sock when you code. Quite a lot there to take in, so I'll just pause for a moment. If anybody's got questions about the browser or anything that's not clear you'd like me to go over again, I'm very happy to do so.
Perfect timing there, Jane. We do have some questions, if I may.
Yeah.
So you mentioned about the red frame. Could you also explain, please, the blue and the green that people are seeing in the browser? Thank you.
I forgot to tell you that one, actually. Let's go back to our gastric ulcer. It's my favourite term for demonstration. So gastrointestinal ulceration and perforation, gastric ulcers and perforation. I usually explain this and I forgot, I'm sorry. So this is multi-axiality. We can activate the legends at the top of the screen. One of the blue buttons is the legends. Gastric ulcer is uniaxial. It's red. It's uniaxial, and I'll go through the three colours and then I'll explain what they mean. The blue one is gastric ulcer hemorrhage or gastric perforation, and this is multi-axial, but this is the primary. So what we're meaning here is if it's red, it only exists in this one sock. Remember we did multi-axiality before. I gave you the example of allergic arthritis. Well, now we're seeing the same. Gastric perforation, for example, if I click on it, on the right-hand side, the primary is gastrointestinal because that's the site of manifestation. But gastric perforation could happen following endoscopy. It could be a procedural complication. So it has a link into injury, poisoning and procedural complication. It could be through a traumatic injury. So that's the secondary sock. And that's what we're seeing on the right-hand side. So blue means that the preferred term itself does have a link into another sock, in this case, injury, poisoning and procedural complications. But the gastrointestinal, what we're viewing here, is the primary. This is what you'd see represented in your listings. The red is uniaxial, it's only in one sock. The blue is in more than one, and this is the primary. So logically, ask yourself, what do you think the green one is? The term is gastric ulcer helicobacter. Well, helicobacter, what does that mean? It's a bacterial infestation, infection, colonization there. So gastric ulcer helicobacter, because it's an infection, it's primary to the infections and infestations and secondary to gastrointestinal. What we're viewing here is the secondary sock, so that's why it's green. If we were to go to the infection sock, that same preferred term, gastric ulcer helicobacter, would be listed and it would be blue. So that's the colour coding. Any other questions, Leander?
That's great. Thank you, Jane. We had a couple of those people came in and asked for that. So that's really great. Great demonstration. We did have another question, and I know you've covered part of this, but what are the secondary sock used for? So we've had some of this, but could you just explain again? Thank you.
They're used for analysis. So here, for example, gastric ulcer helicobacter, in your listing, you'd have reports under the infections and infestations. But if you wanted to see patients with gastric ulcers, maybe your drug might have made patients more prone, even though they've already got the Helicobacter within their system. You may be wanting to analyze, do we have a tendency? Do we have a signal that our patients on our trial or in our database are getting gastric ulcers more than the average person? And you'd need, therefore, to do an additional analysis to group all the gastric ulcers together, and you'd want to include the Helicobacter ulcers there as well as the gastric ulcers where Helicobacter isn't specified. So you'd use the secondary SOC there, not for your primary analysis, not for your listing, but you'd do an additional focus search to answer any particular question or to further investigate what you think is a signal. So we do webinars on this, and as I say, you'd be very welcome to come along, and we'll go into that in more detail. But that's the general principle that secondary SOCs are used for.
Thank you, Jane. Really helpful. And at the moment, that's it for questions.
Right.
But thanks, everyone.
Let's go back to our slides and our coding then. Now we're going to look at how we find the best LLT. So before you go near the browser, you have to ask yourself, what actually is being reported here? Is it a clinical condition, a diagnosis? Is it a sign or symptom before a diagnosis has yet been assigned? Maybe it's not even, it might be an indication, it might be a test result, it might be an injury that's being reported, a procedure or a complication, medication error, all of the other things you see there. And this will influence the way you search. Medication errors and devices and product quality issues, I would tend to advise people to search by going to that particular SOC. For medication errors, I'd go to the injury SOC, and we'll see this when we do some examples later. For product quality issues, again, I'd go to the SOC of product issues to look, and I'd do a top-down search. Whereas some of the others, if it's a symptom or a diagnosis, I'd probably type it in because I don't necessarily know where all the terms in MedDRA are placed. Do you see what I mean? So it might indicate where you find the closest match. If something's reported as a lab result, I know that I need to select a term from the investigation SOC. So I know that I could limit my search to the investigation SOC in the browser, or I could go direct to that SOC and look. Here's an example for you. So the patient suffered from an allergic reaction to an antibiotic. So I'll just let you have a think about it. I don't have a poll for this one. Allergic reaction to an antibiotic. So let's go to the browser. And Leander, you might want to put the credentials in now at this point for everyone in case they want to access the browser and they don't have their own credentials to hand. If you do, that's fine. You can use your own. But if not, we've got a temporary browser demo password that you can use. So allergic reaction.
All done. They're all in the chat for you.
Wonderful. Thank you. Allergic reaction. So let's see what we get if we just type in allergic reaction. We've got 22 terms that contain what I've asked for, allerg reaction. So you see we won't get an exact match because I typed in just the stem of the word. So we've got acute allergic reaction. Well, that would be adding because we don't know it's acute. We know it's antibiotics. We scroll down and then look down and there we are. Allergic reaction to antibiotics is an LLT. The PT is drug hypersensitivity, and it's under allergies to foods, food additives, etc. If we looked at the hierarchy for allergic reaction, that's just hypersensitivity. So this shows you the importance of capturing all that's been reported. The word antibiotics actually changes the PT. Look, it's drug hypersensitivity, not just hypersensitivity there. So I could do a right-hand click, go to the browser. I'm not going to gain anything here because I'm as close as I possibly could be. But as a general principle, it's good practice to go to the browser and look around at the other PTs or the other LLTs under that PT of drug hypersensitivity. Allergic reaction to antibiotics. It's almost the wording we've had in our report. And that's the one I would code. I could do a right-hand click, copy the term, and go over to my coding tool and paste it in. Next one. The patient states she has been experiencing cold sweats. She has been experiencing cold sweats. So what would you search for? If you were to go to the browser, what would you type in to start with? What would be your starting point here? Cold sweats. Sweat, that's a good place, isn't it? We'll test it in a moment when we go together to the browser. Cold, cold sweat, cold sweats. So you've given me all the options I was hoping for there. So some of you searched for the word cold, some for the word sweat, some of you've used the exact wording as cold sweats, and somebody went cold sweat in the singular. So let's go to the browser. I'm going to do what you suggested. Let's start with cold sweats, because that's the exact words, and we usually say try to search with the words that you've been given. Cold sweats doesn't bring us anything. The reason for this is that MedDRA is very much a singular or a splitting terminology. It only looks in the singular. So let's do what another review suggested and look for cold sweat in the singular, and then we find it. There it is, an exact match, cold sweat. The preferred term is cold sweat, and then you see it's multi-axial. I can do a right-hand click, go to the browser, and just check that there's nothing better. But all we had reported was that she had been experiencing cold sweats. There's not going to be a male or female equivalent here. It's just cold sweats. So we've got other synonyms, clammy and clamminess, but cold sweat is exactly what we're looking for. So let's just do to show the impact. If we did sweat, we're going to have a lot more. We've got 59 LLTs to look through now, because we're going to be getting sweat ducts, hot sweat, night sweat, sweat gland, all of these, even tests. So by putting in less, we're going to get more. And then similarly, if we do cold, let's see what we get here. We've got 87 now with different coldness, cold agglutinins, cold sores, coldness, feeling cold. So all of those terms. So by using the exact words, cold sweat, but remember that MedDRA is a splitting dictionary, so it's best not to write the full cold sweats. Well done. Well done.
Jane, just on that example, we had somebody mention skin conditions. I don't know if you would just explain why you wouldn't necessarily skin conditions.
I think what they mean is they're saying cold sweats. We know we've searched for cold, so we could limit to skin. What you're saying, I think, is because a cold sweat, you think it's a skin problem, so you could search for cold and look for skin. That would reduce all the investigations like cold agglutinins, common cold. It would reduce that. Yes, your principle is right that we have got it there, cold sweat. My only concern is, unless with my medical, I may not have the medical knowledge in all situations, and sometimes there are general signs and symptoms in the general disorders like body temperature conditions or complicated other things here, general symptoms. Sometimes I'm a bit concerned that I might miss something if I limit. So I'm not such I don't limit that much when I search. But in this scenario, the approach you used would have been fine. Cold sweat by limiting to the skin, we would have got there more quickly. 19 terms instead of 87. So yes, it's a valid point. Thank you for that. Sometimes I don't trust myself that I don't want to miss something that may not actually be a skin condition. How confident am I that it's a skin condition? But thanks for adding that. It's a really good point for everyone else. Any other tips that anybody's got they want to share with us? Feel free, send us in any tips you've come across in your experience.
Jane, we did just have another question pop in. Cold sweat has 2 HLTs. Do we need to select one or both, or is it predetermined?
It's predetermined. That means the term's multi-axial. Remember the slides we gave you on multi-axiality? You can look back at them after the session. It's predetermined. We always choose the predetermined primary sock, and that primary sock has a path, and that path includes the HLGT and the HLT. So apologies if I went a bit fast at that point, but you can look back after the session. I'm glad you asked, because if you're not clear, there's guaranteed someone else among us today who's not also struggling and missed that point. So if you're struggling, if you're not clear, ask a question, because I'm sure you're not the only one who missed it. Any other questions?
Thank you, Jane. No, that's all for now, but I really appreciate you taking the questions.
Okay, so I'm just looking at the clock. We've got 45 minutes, so we'll go on with these. We've got about another 10, I think, like this. And then what we've got is we've got a few examples that you can actually code for yourself. So we've got plenty of time. We're well on. I can slow down. We can include your questions. So anything you've got questions, let us know. Lab results indicate the patient has increased troponin and increased CPK-MB. And it's given us a clue there that this is an investigation. So I've mentioned a few times, when something's reported as a lab result, we need to code it as a lab result. That means selecting a term from the investigation SOC. So let's go to the browser. We've got 2 here. Remember what I said, when you limit, you must clear it. I've made that mistake so many times when coding myself. So we've got 2 lab results. We could go to the investigation system organ class, but do we know exactly? How good is our knowledge? Do we know exactly where to go? Maybe under investigations, enzyme investigations. Is it tissue, skeletal and cardiac muscle analyses? Probably. So we could do that. Blood creatine phosphokinase, CPK-MB, blood creatinine phosphokinase, MB increased. So there we could find it, CPK-MB increased. But you see how hard that is. That relies on us knowing our test names and knowing the medical background to it. It's a lot easier to type. Oh, sorry about that. A lot easier to type them in here. So CPK, let's see what we get if we just search for that. There we go. We get the abbreviation CPK-MB. We've got the abbreviation as well as the term being written out in full at the PT level. So we want the increased, CPK-MB increased, blood creatine phosphokinase MB increased, and I could go right hand, but I've already been over there. You've seen it. Investigations terms are all uniaxial. Remember we had a slide. They're all uniaxial. They're only in this one SOC. That's relevant when you come to analysis. And there it is. So we choose the abbreviation because that's the closest to what's been reported. And troponin. Troponin, there it is. There are 20 terms, including the word troponin. We've got different types of troponin, troponin I, C or T. We don't know that. That would be adding information. All we know is troponin, abnormal troponin decreased, troponin, where is it? There it is. Troponin increased. Again, right-hand click, go to browser. Will tell you there that it's in the same HLT of skeletal and cardiac enzymes. So you might be tempted to say, well, they're both cardiac enzymes. Is there a term for cardiac enzymes increased? But that would be, we wouldn't do that. So let's look up. We would never lump test results together and select one LLT. We always split code when they have separate PTs, heart enzymes, cardiac enzymes. So don't be tempted to say cardiac enzymes increased, that they're both troponin and CPKMB are all both indicative of cardiac. No, we don't do that. We always split code. So we would split code to troponin increased and CPKMB increased. Patient accidentally took drug Y instead of drug X and became short of breath. So again, we've got a clue that it's a medication error. The patient took the wrong drug, and as a result, they have a clinical consequence. Well, in the MedDRA term selection points to consider document, it tells us that we need to code the medical event, so in other words, the medication error, and shortness of breath as the clinical consequence. We know it's a medication error because we know the patient accidentally took the wrong drug. It wasn't deliberate. It wasn't any kind of misuse of a drug. It was a pure error. The patient accidentally took the wrong drug. They became short of breath. So we need to code the event. First of all, patient took the wrong drug, injury, poisoning, and procedural complications. Remember, I said that personally, I find the medication errors are best to find top down. You'll see why now. If you have a look within the HLT, let me make this a little bit bigger for you so you can see more clearly on your screen. If you have a look at the HLT, you can see that it signposts us. The terms are grouped according to prescribing error, monitoring error, dispensing error, preparation error, and administration errors even. There's confusion grouped. So it helps us to navigate and find the most specific term. So the stage of the medication error. We know that the patient took the drug, so it's an administration error. The wrong drug was taken. So is it incorrect drug? Incorrect drug administration rate. So it's not the word incorrect. Is it the word wrong? Wrong product administered, right at the very bottom. I can look at the LLTs underneath it. Product is more general than the word drug. Product covers vaccines. It also covers devices and other things like maybe cosmetics if people are doing trials, or contact lens solutions, for example. So we would select wrong drug administered because the patient took the wrong drug. And then as a result, they had shortness of breath. So again, I'll type it in the middle, short of breath. We get, there's a term of short of breath, breath shortness, shortness of breath. So what did our verbatim say? The patient became short of breath. So short of breath with a preferred term of dyspnea. We look at the hierarchy again. As I say, for this term, it's a breathing disorder, so it's going to be in the respiratory. No, it's this one, breathing disorders, respiratory disorders. Okay, so those are the two we would need for that one. The medication error itself and the clinical consequence. Patient demographics now. So generally, on that big slide at the beginning showing the scope of MedDRA, it showed that the demographic qualifiers, male, female, neonatal, senile, adolescent, any of those, childhood, are out of scope of MedDRA. MedDRA terms don't typically have male and female or any of those others attached to them unless it's relevant to the condition. So, for example, breast cancer, you'll find there's a male breast cancer and a female breast cancer. Infertility, there'll be a male and a female option at the LLT level, PT level. Because it's different, isn't it? Infertility is a different medical entity in a male from a female. So here we have one where we're told it's a 2-day-old baby was noted to have a mild fever. So what would you search for here? What would you enter when going to the browser to try and find the closest term? Fever, mild fever, mild fever. You remember that, going back to that diagram with the big blue circle in the middle? I'll just give you a moment while you fill out. As I said, I didn't spend long on it because I wanted us to get onto the coding elements today. One of the other things talked about severity criteria, and severity criteria are also out of scope of MedDRA. So there are a few terms in MedDRA which say mild, moderate and severe, or slight, or borderline. There are a few, but not that many. So just as a general guide for you, don't be surprised if you don't find many. And generally mild, moderate and severe is not where I would look first of all, because there aren't many terms that have mild, moderate or severe associated with them. Mental used to be mental retardation, but I don't know if it's mental impairment now is the wording for it. Okay, so let's have a look at the browser. I see we're quite good consensus there. Most of you are interested in looking for fever. Somebody said pediatric, so you're looking for the concept there. So fever, we've got 191 terms, so that's quite high. Ideally, I'd rather not have to look through all these fevers. So I could go to the general disorder SOC, where I know that the terms, the body temperature conditions are all grouped together there. That's one way of doing it, looking for febrile conditions. Under there, I've got, and there's some terms I can look through, or I can do a bottom up and type it in here. So the baby is 2 days old. So would I say the baby's newborn or neonatal? These are synonyms. So I typed in newborn, and it gave me the synonym of fever neonatal. That's because newborn and neonatal is part of the search at the top. So fever neonatal. So because the baby's 2 days, generally the neonatal period is taken as 28 days. So that would be our closest. And that has a different placement. It has a link into the newborn complications as well as being in the HLT of febrile disorders where we were looking. So I could look in general, body temperature conditions, febrile disorders, and then find my fever neonatal here. But it's worth capturing that it is neonatal because the baby's 2 days old. So that's the point I wanted to make there. Next one is an indication. 35-year-old woman was taking drug X to prevent relapses of multiple sclerosis. So what would we do here? So here we're told it's an indication. It's to prevent it. So we type in prevent multiple sclerosis. I've obviously done this search before. Prevent multiple sclerosis. No. So the issue we have here is the word prevent. And after you've been using MedDRA for a while, you'll get familiar with the conventions really. And MedDRA tends to use the word prophylaxis. So when you are coding indications, bear in mind that we try, if we have something that's being used for prevention, try with the word prophylaxis if prevention's not in there. There are 1 or 2 words terms that use the word prevention, but generally let's look for prophylaxis. Multiple sclerosis relapse prophylaxis. That's exactly what's been reported. We're not using it to treat multiple sclerosis. We're actually using it for prophylaxis. And because it's prophylaxis, it's in the procedures, surgical and medical procedures system organ class. And that's quite common for indications to fall into the procedures SOC. So think about it. We're not treating the disorder. When you have a report like this, it's being used for prevention. Next one. She had a pathologic fracture of the neck of the left femur. Pathologic fracture of the neck. Let me see if I gave you this one. No, I didn't give you this one. You can have a think though. What would you look for? Pathologic fracture of the neck of the left femur. Well, let's have a look together. It's a fracture of the femur. So let's start with femur fracture or fracture femur. Let's see what we've got. We've got a term which just says fracture femur, but we know more than that. We know it's the neck. So we've got closed femur fracture, quite a lot there. The head, the shaft, the lower end, the neck. There's a term there for neck. Fracture of neck of femur, femoral neck fracture. Let's put in neck and it will narrow our results. So there we go again. We've got fracture of neck of femur here, and we look at the hierarchy. Femoral neck fracture, which is under limb fractures. It's multiaxial and also under the injuries. So the fractures are primary to injuries, even though they affect the bones and the leg, because you would assume, or we would take it, unless otherwise specified, a fracture is going to be a trauma. It's an injury, a fracture. It's only when it specifically states that it's a pathologic fracture that you would look for pathological fracture. And here we see we've got an LLT, pathologic fracture of neck of femur. So this actually has a completely different hierarchy. The preferred term is pathological fracture. So we lose the site of the fracture, but it doesn't matter, because what's most important here is that the patient didn't have a major trauma which caused the bone to break. They've got some underlying condition. And we see here from the HLTs, it links into fractures and dislocations not elsewhere classified. So that's the injury SOC. It links into fractures not elsewhere classified, which is musculoskeletal, which is our primary. And it also has a link into the oncologic emergencies, complications and emergencies, because patients with bone metastases could be prone to fractures. So it's triple. It's got three links there, one primary and two secondary. The primary here is musculoskeletal and connective tissue. So we would select pathologic fracture of the neck of femur. And you see the difference, because just coding fracture neck of femur would put it in injury, poisoning and procedural complications, but here it's gone into musculoskeletal. So it really is important to check the hierarchy and get the closest term, because here we'd be coding in the wrong SOC if we'd missed the pathological element in our term selection. Following the procedure, the patient experienced several days of constipation. So this is another example of specificity. What would you search for in the browser? Constipation, that's a good starting point, yeah. Constipation, prolonged constipation, several days, prolonged. Anything else to pick up from that term? Anything else to pick up from the report you've been given? We're all going to look for constipation. Anyone going to look for anything different? Post-procedural, thank you, whoever said that. Let's try and capture the fact it's post-procedural. It's following the procedure. Post-operative, post-procedural. Acute, well, have we been told it's acute? it's only started following the procedure, but we would then, if we coded to acute, we'd be adding information because we haven't been told it's acute. So just because it's post-operative doesn't mean it's necessarily acute. Procedural constipation or post-procedural complication. Wonderful. Let's go back and have a look in the browser. So we can do exactly what you said. Constipation. That was the first suggestion you gave me. And we've got 15 terms, so we can look through them. Just make sure you look through them carefully. And there you find either iatrogenic, which is due to treatment in some way, or post-procedural is another option, or post-operative is another option. So of those three, post-procedural is the closest to what's been reported, following the procedure. Post-procedural, if I didn't have that, I'd probably select the post-operative, but I can be more specific, post-procedural, and I can see on the right-hand side, or I can click up the hierarchy. It's in the injury, poisoning, and procedural complications. There it is. It's a different SOC again. Because it's post-procedural, it puts it into the injuries, whereas general constipation up here, if we looked at the placement of that, it's gastrointestinal. So that shows you the difference. It's worth capturing as much as you can of the reported event because in some cases it changes the SOC. A 66-year-old man died from a ruptured aortic aneurysm. Well, the point I would like to make here, and this is one of the principles in the points to consider document that I said we'd touch on some of them. This one is about death. When we have a cause of death, we code the cause of death. We don't code death itself. We don't need to code death because we have another field on the form where it's captured as an outcome elsewhere. So all we're interested in, when we know the cause of death, we look to code the cause of death. That's what's underlined here, and that's what we're going to look for. So that's the principle to remember from this one. You only code death if you don't know any other information. I'll do this one and then we'll stop for questions. Ruptured aortic aneurysm. There it is. Aortic aneurysm rupture. That was the cause of death. We don't need to code death as well. Aortic aneurysm rupture. Okay, vascular disorders. Okay, we'll go back there. Let's do one more. Product quality now. It was determined that the product was counterfeit. So we're told it's a product quality issue. If you didn't have that at the top of the slide, would you remember that there's something wrong with the product? It's nothing to do with the patient. So let's go and have a look. Remember I said this is one of those terms that I would go top down. So I would go product disuse. There's the SOC on the left-hand side, product disuse. Click on that, open up. We see we've got product quality, supply, distribution, manufacturing, quality. The other HLGT is for devices. So let's open it there. And again, we see immediately counterfeit. There's an HLT ready for us. Counterfeit, falsified and substandard products. That's where we find it was determined that the product was counterfeit. It doesn't tell us that the patient took the product. The patient may have realized it. Let's go back to our verbatim. It was determined the product was counterfeit. So it's not a medication error. It's not a case that the counterfeit product has been administered, just that the product is counterfeit. It was determined. So we've got product counterfeit here as our option. It was determined the product was counterfeit. So the thing there to remember is if you have these, do try top down. It's a lot easier to go top down in the product disuse SOC. Okay. I think I've only got a couple left. The patient was confined to a wheelchair. What would you code this one to? What would you search for? This is an interesting term because it's a different section of MedDRA that we haven't yet gone to so far today. The patient was confined to a wheelchair. Disability. That's a great start. Thank you. That will help us in finding where we're going. Wheelchair bound. Wheelchair is certainly a key word, isn't it, for our search? Social circumstance. Somebody's there before me. Look, well done. That's exactly what I wanted to point out. This one is actually a social circumstances. We don't know the cause. We don't know why the patient's in the wheelchair. So we can't code the disease. We need to code their situation or their disability or their social circumstance. So that's why disability is the signpost that's going to help us find where we're going. Thank you for that. Let's go to the browser. So you told me it was social circumstances, you told me it was disability, or you told me to search for wheelchair. So let's do all of these. Wheelchair is one approach. Search for wheelchair, we get wheelchair user. The PT is wheelchair user. It is a disability issue, lifestyle issue, and it's in social circumstances. So that's one way of doing it. Exactly right. Well done. The other way is to click on social circumstances. When you get more familiar with MedDRA, you'll remember that disability comes under lifestyle. Open lifestyle, there's the disability HLT, and we can navigate there. This is where we have other product device users. We have terms for things like denture wearer, corrective lenses, and this is where hearing aid, hand prosthesis, all of the common devices. And then we have wheelchair user right at the bottom. There it is. So that's where we'd find it. So you can do either way, top down or bottom up. Product errors now. The pharmacist made a mistake in compounding of the medication. The pharmacist has made the mistake. So we, again, top down, injuries, find the stage of the medication error. And here it is, product preparation or dispensing. Well, the nurse was the pharmacist rather, was compounding. So what I'm going to do is I'm going to go to my concept descriptions at the top. I'm going to look at the C. What does compounding mean? Compounding refers to products that are made by a pharmacist or physician. Compounding. So if they're making it, are they dispensing it or are they preparing it? Well, let's have a look under preparation. Product preparation error. We're told it's a mistake. So then it's an error, not an issue. We know that it's a mistake. We know it was unintentional. And there's a term right there, product compounding error. So we got there through looking up the definition or the description of compounding, knowing that it's a way of preparing and looking there. I could have looked under dispensing if I wasn't sure. Pharmacists commonly dispense, but that's where we'd find it. A mistake. The key word here, mistake, means that it's an error. We know that it was unintentional. If you're interested in medication errors, we offer specific webinars into the coding of medication errors. So we have the advanced coding next week, and then later on this year, there'll be one specifically on medication errors. So if you're interested, do come along. We'd love to have you back and quizzes again and to help you there. So this one, I'm not going to go through this one in detail. I'm going to take your questions now. This one just shows you that in terms of a narrative, we know that it's a 75-year-old male receiving drug X for rheumatoid arthritis. That's the indication. That can be coded with MedDRA. He developed symptomatic aortic valve stenosis. So that's his presenting symptom or diagnosis. Again, we can code that. Patient's medical history, colon cancer. He's a cigarette smoker. So we'd code the cancer. We'd look in the social circumstances for being a smoker. He's a cigarette smoker. Then he underwent an aortic valve replacement. So the treatment, the procedural treatment. And as a result, he developed a sternal wound infection. So he has a post-operative complication 3 days post-surgery. So you see how we're using the whole scope of MedDRA to code everything, right from the indication, the diagnosis, complications, procedures, medical history. Okay, so questions, Leander. What have we got in our questions before we move on to the group doing some coding for themselves?
We had a couple of comments. So one in particular was around the prevent and the prophylaxis example. So the attendee was asking, for those who aren't used to dealing with medical terms so often, could MedDRA usefully offer options or synonyms for these words directly during the search? Or else is there an easily consultable dictionary for common words? I don't know what your thoughts were.
So these are the synonyms. We can look through them. There are a number of them in there. It's not in there. Prophylaxis and prevention. There's no reason why it couldn't be in there. It just needs to be, we don't make a lot of changes to this. You can see we added COVID-19. That one was added. Yes, it's a good point that you make there, that it could be added. There's no reason why not. It isn't at present. We are working on a new release of the browser, so it might be a good time that I can pass it on and suggest that this list of synonym does get reviewed, and that would be a useful addition. I'm sure there are others as well that we could think of, all of us together. So yes, thank you for that comment. I'll pass it on. As I said, it's good timing because we're currently working on a new enhanced release of the browser.
That's great. And just while you've got the browser open, could you just one more time mention the difference between the coloured rings again around
yes, of course.
One more time, thank you.
Multi-axiality. Open the legends. I went fast, I know. It's because some of you, I know, have got more experience than others. So gastric ulcers, gastrointestinal ulceration and perforation. When I look at the gastric ulcers, they've got different colour coding. Gastric ulcer is only in one sock. It's gastrointestinal. It's only in this one sock. That's why it's red. It means it's only in this sock. So this is the primary. This is what you'll see in your listings. The blue one, gastric ulcer hemorrhage. Let's use this time. Hemorrhage is a vascular problem, bleeding. But the site is gastric ulcer. So because of that, the site is the primary sock, and that's why we're looking in the gastrointestinal sock. This is the primary sock. We can verify that on the right-hand side. And when we do our listings, that's where that report and any of other reports like it, gastric ulcer hemorrhage, will be under gastrointestinal. That's what the blue means. But the green one is gastric ulcer helicobacter. That means what we're actually seeing here within the gastrointestinal sock, what we're actually viewing is the secondary sock. This here, up the top here, gastrointestinal, that term gastric ulcer helicobacter, you see they're gastric ulcers, because it's green, it's actually primary to the infections, because Helicobacter is an infection. All the infections in MedDRA are grouped together, and that's why it will be. If we go to infections, infection sock, bacterial, Helicobacter, is it there? There it is. It's an HLT in its own right. So the same term, gastric ulcer helicobacter, is blue here. This is because this is the primary placement under the infection sock, and that's what we'd see in our listing. Okay, Leander? Is that
We did have one more that said, yeah, very helpful, thank you. We have one more that said, how would you code peptic gastric ulcer as gastric ulcer or peptic ulcer?
We don't typically do specific verbatims. Before you all get your peptic ulcer, we don't typically. Let's have a look and see if it's straightforward. Peptic ulcer could be it's peptic ulcer, or I'd need time to have a look at it and consider. Peptic is more around the mechanism type. It's peptic ulcers. It's one of those, if you had it a lot, you would, if you saw it a lot, you'd have a convention. If it was a common thing, that's the kind of thing. If you saw them together, you'd have a convention written in your own internal documents so that you were always consistent which one you choose. I'd need time to go away and have a look and really think it through, because they're both PTs. So you'd need to make a call, one or other. Sorry, I can't give you a straight off answer today, but at least other people can appreciate your dilemma. This is an example where you would have a convention, write it down, and always do the same thing. I'll come back to you, but on email on that one. Okay, so let's do some yourself. I make it that you now have 10 minutes. So now Leander's put some details in the chat. You're going to do what we've just been doing, and we'll talk about your options. Here's the polling if you didn't have it before. Here's the browser, details for the browser. You can copy it from the chat. You can use your own credentials if you wish. And here's the first verbatim. She was diagnosed with pneumonia caused by COVID-19 infection. What would you code this one to? So you go to the browser. I'm going to give you a bit more time now so that you can, I know I've gone quite fast today. There's a lot to fit in, and I rely on you telling us if you need more. If you need more clarification, more explanation. Let's go to the poll. What would you code it to? Yeah, we seem like we're all agreed. This is a good example of a combination term. Sometimes MedDRA, we said that MedDRA splits. MedDRA's a splitting dictionary. And remember when I asked you about the non-current terms, I told you how there was one of them, sleep apnea with insomnia, and that was non-current because it was a combination term. And so MedDRA typically doesn't have combinations, doesn't like due to terms, too many of them, but sometimes it's necessary. Here we had a very common thing that occur with if you were working on COVID studies or any studies, I'm sure you were seeing patients coming in reporting COVID-19 pneumonia during the pandemic time, maybe even now. So there's sometimes a need. We saw diabetic retinopathy before, allergic arthritis. These are combination terms with two concepts. Here we're seeing the infective organism and the complication of pneumonia. Exactly right, COVID-19 pneumonia. If anybody wants me to show you how we find it, then let me know. Otherwise, let's do the next one. You all got that one right. A woman ingested her husband's blood pressure drug by mistake. So see what you make of this one. Let's see if I can put it on the next poll slide. There it is. It's on the poll for you. Elderly woman ingested her husband's blood pressure drug by mistake. Accidental medication error, wrong administration drug. Oh, we've got a difference of opinion now, so. Accidental exposure of drug, somebody's saying. Accidental ingestion of drug. It's exposure, isn't it? So ingestion, exposure, is it a drug administration error? Wrong administration of the drug. So let's think about it together. she's not intended to take the drug. So there was no error in administering the drug because the woman took it by mistake. She wasn't the intended patient for the drug. So we wouldn't code it to a medication error or an administration error because it isn't the fact that the wrong drug was administered. And it wasn't even really that the drug was administered to the wrong person because the drug hasn't been administered as such. She took it by mistake. She might have not even realized it was a drug. So it may be the color, or she got confused. She thought it was food, or we don't know. So what we've been told is accidental ingestion or accidental intake of the drug. We code the concept we've been given. And here it is that she swallowed the drug by accident. She ate the drug. She took the drug. She ingested the drug by accident. So let's stick with that because it's not really a medication error because she wasn't the intended patient and the drug wasn't administered to her. So it's not wrong patient got the drug, not wrong drug administered. It's accidental intake or ingestion of the drug. So we've got accidental drug intake by child or accidental product intake by child. Well, that's not very helpful because it's the wife of the. So let's do a right-hand click and go to the browser, see what else we can find. And we see here we're in the HLT. It's within the medications errors and issues, but it's not administration errors. The HLT is accidental exposures. And some of you picked up on this very nicely, that accidental drug, it's not accidental drug intake by child. It's accidental exposure to person by an accidental exposure to product by elderly person. Weren't we told she was elderly? Let's go back. Elderly woman. So we're even told she's elderly. We can capture that as well. Let's go back to our browser. I was looking for an exposure, but actually the elderly one is more specific again. Accidental exposure to product, accidental ingestion of drug. So we could say it's accidental ingestion of drug because we know it's a drug. But we could also say, because she's elderly, let's have a look at the PT for that one. Accidental exposure to product by elderly person. It's a more specific PT. Look, accidental exposure to product versus accidental exposure to product by elderly person. So this one, although it says product, not drug, it is actually a better match because I'm able to capture the elderly at the PT level. And remember we said at the beginning, the PT is used for the analysis. So we want to capture as much as possible. So we would go accidental exposure to product by elderly person. 3 more for you. I see we're getting close on time. The patient developed hyponatremia while hospitalized. What would you go here? Hospitalization is a severity criteria, really. So MedDRA doesn't code hospitalization as such. Not on its own, standalone, if you know the cause, if you know the reason. So the idea with hospitalization is we code it if we don't know the reason why. It's a bit like death. But if we know that it's been, if we know the reason, then we would code the reason. That's just, I'll throw that in while we're here. Some of you have found a very nice term there, hospital-acquired hyponatremia. So it's a combination term. It's a bit like our post-operative, post-procedural constipation. It's always worth having a look. Hospital-acquired hyponatremia, and that will have a different placement. Let's have a look, hyponatremia. I'll show you the placement. It's worth capturing as much information as possible because hospital-acquired hyponatremia, it has a PT of hyponatremia, exactly the same. It's a different LLT, but the placement is the same. So it's worth capturing, but you're getting the detail at the LLT level only, but it is worth choosing the closest LLT. Well done, those of you that found that one. Very nice. Nurse noticed that the injection solution had an unusual odour. So think again, what's happening? What are we being told here? What type of term is it? The nurse noticed that the injection solution had an unusual odour. I realise we're on time now at 11 o'clock, so bear with me. I'm just going to finish this last one. If you need to go, I apologise. I'm only going to be a couple of minutes. It is a product quality issue. That's a great start. Thank you for that. Exactly right. You took the words out my mouth. It is a product quality issue. There's a problem with the odour of the product. So we want to code more specifically than quality issue. We want a specific term. Look at the spelling of the word odour. It's given us the US English spelling. So we want to code that if we can. And product odour abnormal is exactly what you want. You got there. I would just look, can we code abnormal? Can we find the American English breast milk, skin odour, stool, urine odour, no odour, no, oh, there it is, product odour abnormal. So it's got the British spelling at the PT, as you'd expect. But at the LLT, we have a choice of British or American. We match it to what's been reported. Product odour abnormal, we've got both options. So there we would select the American English, product odour abnormal. Because it's an injection, that's the closest we can get. Well done. Thank you. Somebody's entered it. Thank you for that. And then the last one, elderly woman complained her arm was tender where she had received her seasonal flu vaccine. Her arm was tender where she had received her vaccine. So what are we going to code this one? This is a type of term we haven't looked at yet today. So it's a good opportunity. Injection site tenderness. Tenderness is what she's reporting. We've got a hangover from hospital-acquired hyponatremia. It is a vaccine, exactly. It is a vaccine. So we're getting there between us all, teamwork. Vaccination site tenderness is more specific than injection site tenderness. It's following a procedure. You've highlighted that it's following a procedure. So that's your right. We need to pick that up. We need to pick up its post-vaccine. Vaccination site tenderness. Exactly right. Let's have a look. We know it's a vaccine, site tender. And there it is. Vaccination site tenderness. It's under the PT of pain. Vaccination site pain. So if I was looking for a site reaction and I couldn't find tenderness, then I would look for pain, because MedDRA treats tenderness as a synonym of pain where it's at the LLT level. So vaccination site is more specific than injection site. Just go to the browser for completeness. And there we see that the vaccination sites are in an HLT of their own. Very important following the pandemic. So there's a big push around vaccination site reactions to get them all in MedDRA. Injection site reactions are separate. You should have everything there that you have as a vaccination. And there they are. So tenderness, we find it. It's under the PT of pain. There it is. And we can choose the closest. We've also got stinging, burning, and tenderness. So we look for a site term rather than just capturing the disorder itself. Well done. Well done. Thank you for participating. So a bit of a rush there at the end. We've discussed the scope, structure and characteristics of MedDRA. We've discussed coding conventions, but in particular, the MedDRA term selection points to consider. We've done the browser. We've done some together and you've done some on your own. So well done. It's been a really fun session to do together with all of the interaction. Thank you for that. Here are some useful links for you to the website, the browser, whatever you need, the change requests, support documentation where you can access the points to consider documents. And that's everything. So if you've got any questions, I'm happy to stay and take your questions. Otherwise, Thank you so much for all your interactions today. Remember, we're going to be back next week, same time, same place, for advanced coding. So if you haven't already signed up, we'd love to have you with us. Similar again with interaction and lots of principles being discussed. Leander, do we have any questions?
We have two asks, please, Jane. Could you show the YouTube channel, if you would? And secondly, would you show again where we can find the synonyms? That was helpful when you showed it, and I know you've showed it a couple of times, but it always helps. Could you just show it one more time?
The synonyms are there. It's the hyperlink in the middle of the browser. Use synonym list. When you click on that, you get the pop-up box that you saw. Here we are. You click on that and you get the pop-up box. That's the synonyms. And
fantastic, thank you.
And the YouTube channel, certainly happy to show that. YouTube channel. So come here. I always have to search for YouTube. Oh, YouTube. There it is. And I've got the MedDRA channel bookmarked. There we go. MedDRA MSSO. There's our channel, and there are playlists here. So you can either choose the webinars you're interested in. If you have a favorite instructor, because I've got a number of my colleagues who do them as well, in all languages and time zones. So we mentioned what is MedDRA and how's it used. It was done just a few days ago. So if you are very new to MedDRA, there's my colleague Suzanne Shaker. You can see Suzanne's recording from 3 days ago. There's the advanced MedDRA coding there. I'm not sure who did that one a couple of months ago. I haven't done them for a while. So, but if you click on playlists, then you'll see the various, I've got a playlist with some here, on my past webinars. There's also some Let's Code Together that we'll talk about next week that are more advanced that I do with a colleague. That's a step on from the advanced webinar. So again, that's one you'd be very welcome to come to if you see. And you can choose your language, choose your instructor and your topic. Anything else?
Thank you, Jane. There's no other questions.
Wonderful.
Thank you very much. We've
Right.
got some great feedback. We always appreciate your feedback, and you will get a survey at the end of this webinar. So yeah, please do share with us your feedback, because it really helps us plan for the next session. So yeah, thank you. And thank you, Jane. Great session as always.
Thank you for your collaboration. Apologies, we're 7 minutes over. Just the last point, if you weren't here at the beginning, you need to have been here for the whole session. We just make a small allowance for a few minutes if you're late logging in, a few minutes at the beginning if you have difficulty. Otherwise, in order to get a certificate, you have to have been here for the whole session, and you download that from our self-service application. Don't email us to ask for it. You get it yourself from the self-service application. And that's here, self-service application. Okay, that's everything, Leander. Stay safe, everyone. Have a good day and hope to see you next week. Bye for now.
Thanks, everyone. Bye-bye.